This 16-minute tutorial will review what you would otherwise learn in several hours in the classroom. I will teach you about the clotting cascades, where each medication affects the clotting cascade, review each medication category, and also provide some bonus practice questions to test your knowledge at the end. I hope you enjoy learning about the clotting cascade and anticoagulant medications. In this tutorial, we will review coagulation-altering drug categories, including the antiplatelet drugs, vitamin K antagonist, factor Xa inhibitors, thrombolytics, and indirect thrombin inhibitors. Before we learn about the various medications that alter clotting, let's review the different clotting cascade pathways. When a tissue injury occurs in the body, bleeding starts. This initiates the clotting cascade, with the final result being a fibrin clot. There are two different pathways within the clotting cascade, the intrinsic and extrinsic. Let's first look at the intrinsic pathway. Factors 11, 12, 9, and 10 are included in the intrinsic pathway. After a tissue injury occurs, factor 12 is converted to factor 12A. You'll see that conversion of each factor within the cascade serves as a catalyst to convert the next factor below it. The endpoint of the intrinsic pathway is where factor 10 is converted to factor 10A. This is where the intrinsic pathway merges with the extrinsic pathway. Now for the extrinsic pathway. The only factor conversion that takes place when injury occurs is factor 7 to factor 7A. Factor 7A, in combination with a tissue factor, are the catalyst for converting factor 10 to factor 10A. Similar to this tissue factor on the intrinsic pathway, you may have noticed a mystery factor on the intrinsic pathway side. This mystery factor is factor 8A, a factor associated with the bleeding disorder hemophilia A. Before converting to factor 8A, factor 8 is bound to another factor called the von Willebrand factor. When injury occurs, factor 8 separates from the von Willebrand factor and becomes activated as factor 8A. Factor 8A in combination with factor 9A on the intrinsic pathway and tissue factor in combination with factor 7A on the extrinsic pathway are the dual catalysts for converting factor 10 to factor 10A. Progressing forward on the cascade from factor 10A, there's a common pathway now which leads us to the outcome of clotting. Factor 10A and factor 5A are the catalysts that convert prothrombin to thrombin. The presence of thrombin will activate platelets and convert fibrinogen to our final product of fibrin, which is the clot. Keep in mind that conversion of different factors in both the intrinsic and extrinsic pathways may include additional catalyst products such as calcium or phospholipids, which I didn't expand upon in this example. Now let's learn about each drug category, which affects various aspects of the clotting cascade. First are the antiplatelet drugs. There are a variety of different types that affect different parts of the platelet adhesion process. All of the categories, however, will affect the activated platelets here, which decreases the effectiveness of the fibrin clot. The prototype drug for the antiplatelet category is clopidogrel, otherwise known as Plavix. For platelets to adhere to one another, adenosine diphosphate must bind with receptors on each platelet. Once this occurs, platelets will aggregate together, forming a clot. Clopidogrel works by inhibiting this process by blocking the receptor sites on the platelet. This permanently affects the platelet for the remainder of its lifespan, which is around 10 days. Metabolism of clopidogrel is dependent on the CYP450 enzymes. Therefore, any competition from other drugs using this metabolic pathway may interfere with how the drug works. Adverse effects include excessive bruising, bleeding, rash, or flu-like symptoms. Patients taking this drug category should avoid other drugs that affect coagulation, like aspirin or Coumadin, and if the patient is having a surgical procedure, this drug should be discontinued at least 5 days prior to the procedure due to the prolonged effect the drug has on platelets, which would increase the patient's risk for excessive bleeding in the surgical procedure. Next are the indirect thrombin inhibitors. There are a few groups within this drug category, but all have the same end result of preventing production of thrombin. The indirect thrombin inhibitors prevent conversion of factors 12, 11, 9, and 10 from converting to their active forms 12A, 11A, 9A, and 10A on the intrinsic pathway, and tissue factor on the extrinsic pathway is inhibited, preventing conversion to 10A. Because the clotting cascade is halted with interruption of any one of these factors, prothrombin cannot be activated to thrombin and a fibrin clot is not formed. A well-known indirect thrombin inhibitor is the drug heparin. A common suffix is PARIN. Other examples include enoxaparin or dalteparin. As we just discussed, conversion of various factors are inhibited by this category of drug, and heparin products have specific action on factor 10. Just like other anticoagulants, adverse effects include excessive bleeding and bruising. Heparin is rapid-acting and subsequently has a very short half-life. This means that the drug will work quickly when needed, but if discontinued, the effects do not stay around for a long duration of time. If a hemorrhagic event occurs in a patient receiving heparin, protamine sulfate can be given to counteract the anticoagulant effects. To monitor the effects of heparin, a PTT is a laboratory test that provides objective information regarding clotting times. In general, clotting time should be 1.5 to 2.5 times the normal control value. For example, a normal PTT range is 25 to 35 seconds. If heparin is administered, the PTT range might increase up to 60 to 90 seconds. The next drug category we will review are the vitamin K antagonists. Vitamin K is an essential cofactor that affects activation of various factors on the clotting cascade. Without vitamin K, several clotting factors cannot be activated and the cascade is halted, preventing formation of a fibrin clot. Factors 9A, 7A, 10A, and prothrombin are affected. The prototype drug for vitamin K antagonists is warfarin sodium, otherwise known as Coumadin. As we just discussed, absence of vitamin K inhibits activation of factors 2, 7, 9, and 10, which prevents formation of a fibrin clot. Adverse effects include excessive bleeding and bruising. Coumadin has numerous interactions with herbal products and any food or drink that contains vitamin K. Herbal products that start with the letter G tend to be the ones that affect Coumadin. If excessive bleeding occurs in a patient taking Coumadin, vitamin K is the antidote that will counteract this adverse effect. A unique thing to know about Coumadin is that the onset of action is anywhere from 2 to 7 days. This means that any changes in the dose or addition of other drugs which may affect Coumadin will not be evident for 2 to 7 days. The laboratory test that objectively measures the effects of Coumadin is the INR. A typical value is less than 1. However, patients taking Coumadin, the desired range can be anywhere from 2 to 4, depending on the patient's diagnosis. A prothrombin time is another laboratory value that's useful to measure in combination with an INR. Like the PTT, a normal range is 1.5 to 2.5 times the normal value, which is typically 9 to 12 seconds. The last anticoagulant category I'll review are the direct-acting factor 10A inhibitors. This category was first approved by the FDA and released back in 2011 as an alternative to Coumadin. This category works by inhibiting conversion of factor 10 to factor 10A, blocking formation of thrombin and fibrin. Currently, there are only a handful of direct-acting factor 10 inhibitors. A common suffix among this group is XABAN, for example, rivaroxaban or apixaban. As we just discussed, this category works by inhibiting conversion of factor 10 to factor 10A. Like the other anticoagulants, the common adverse drug reaction is excessive bleeding and bruising. Up until 2018, there was not an FDA-approved antidote for this drug category, but currently the drug andexanet alpha can be given to counteract the effects of this category when necessary. There are several benefits this anticoagulant category has over Coumadin. When initiating the drug, clotting time laboratory tests are not required, and there are far fewer drug and food interactions, making the drug easier for the patient to take, improving compliance of pharmacotherapy. Now let's throw this clotting cascade to the side and learn about medications used to break down a fibrin clot that's already been formed. This is called thrombolysis. To reverse the effects of the clotting cascade, thrombolytic agents will be given to convert a substance called plasminogen to plasmin. Plasmin is a substance with the ability to break down a fibrin clot into fibrin particles. A common thrombolytic drug that's used is called alteplase. This agent is used in patients with acute clotting events like heart attack or stroke. It's also used off-label to clear clots that may have formed within intravenous lines. As we just discussed, the drug works by breaking down plasminogen to plasmin, a substance that dissolves fibrin clots. As you would expect, adverse drug reactions include risk of bleeding or bruising. This can manifest as epistaxis or bloody nose that will not stop, or in rare cases, intracranial bleeding, a life-threatening event. If the patient has had recent traumatic brain injury, surgery, or internal active bleeding, such as a stomach ulcer, the risks and benefits should be considered before administering alteplase. Just like my other tutorials, we are now going to go through some practice questions related to the content we just reviewed. You will have 10 seconds to formulate your answer. If you need longer than 10 seconds, feel free to pause the recording after the question is read. Which items should be avoided if a patient is taking warfarin sodium after experiencing a heart attack? Select all that apply. Prunes, spinach, green tea, white rice, kale. Because warfarin sodium inhibits vitamin K from activating multiple factors on the clotting cascade, patients taking this drug should avoid diets high in vitamin K. Vitamin K is the antidote to this drug, therefore consuming vitamin K would counteract the effectiveness and place the patient at risk for clotting. Of the options available here, prunes, spinach, and kale are all high in vitamin K, therefore should be avoided. Green tea, a G herbal product, which interacts with coumadin, also decreases effectiveness, therefore this should be avoided as well. When injecting heparin, which of the following are correct practices to minimize adverse effects of this drug? Select all that apply. Heparin should be administered intramuscularly. The injection site should be massaged after injecting heparin. With injection, aspiration should not be performed. Heparin is only given via the parenteral route. The APTT, activated partial thromboplastin time, is a laboratory test that measures heparin efficacy. Anticoagulants administered by injection, such as heparin, have specific technique to avoid bleeding and bruising. Heparin is poorly absorbed when given orally, therefore it must always be given parenterally as an intravenous infusion or subcutaneous injection. When injecting subcutaneously, the syringe plunger should not be drawn back to aspirate once the needle has entered the skin. Massaging the injection site should also be avoided. Both aspirating and massage can cause excessive bruising, bleeding, and tissue damage. The activated partial thromboplastin time is a laboratory test that will be used to determine the efficacy of heparin. A pediatric patient diagnosed with Kawasaki's disease requires antiplatelet therapy. Which one of the following medications is appropriate for this patient? Aspirin, Coumadin, Alteplase, enoxaparin, edoxaban. Of the medications listed here, aspirin is the only drug categorized as an antiplatelet agent. Although aspirin is generally contraindicated in the pediatric population due to risk of a life-threatening condition called Ray's syndrome, the benefits outweigh the risks in patients diagnosed with Kawasaki's disease. Ray's syndrome more commonly occurs when aspirin is given to patients experiencing viral illnesses, specifically influenza. Of the other drugs listed here, Coumadin is a vitamin K antagonist, Alteplase is a thrombolytic, enoxaparin is a low molecular weight heparin, and edoxaban is a factor Xa inhibitor. The INR results for a patient receiving warfarin sodium are 5.0. The provider adjusts the dose in an attempt to decrease the INR. When should the provider expect the INR to decrease following the change in dose? 12 hours, 24 hours, 36 hours, 48 hours. The onset of action of warfarin sodium, otherwise known as Coumadin, can range from 2 to 7 days, and the bioavailability, though highly variable among individuals, is on average 42 hours. Therefore, when changing the dose, the provider might see the INR decrease as early as 42 hours, or it might take up to 7 days. 48 hours would be the best choice of the answers available in this question. A patient taking Xarelto following a diagnosis of pulmonary embolism arrives to the ED following a motor vehicle accident with suspected traumatic brain injury. To avoid internal hemorrhage, which of the following would reverse the effects of Xarelto? Vitamin K, Andexxa, protamine sulfate, activated charcoal. To reverse the anticoagulant effects of Xarelto, the drug Andexxa was approved by the FDA in 2018 to reverse the effects of Xarelto in emergent situations where anticoagulation may be life-threatening. You have reached the end of the coagulation-altering medications tutorial. We hope you've learned more about the clotting cascade and the medications used to affect coagulation and clotting. As always, best of luck on your learning journey.